This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2018, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Severe Asthma Attacks in the ER. Brady Scott is a registered respiratory therapist and fellow of the AARC. Brady is Director of Clinical Education and Assistant Professor for the Respiratory Care Program at Rush University in Illinois. Brady discloses relationships with Synovian Pharmaceuticals and Bayer Pharmaceuticals.
So let's talk about acute severe asthma or status asthmaticus. Defined, severe asthma is asthma that is unresponsive to repeated courses of beta agonist therapy, such as inhaled albuterol, levoalbuterol, or subcutaneous epinephrine. Generally, this is considered a medical emergency, and it actually accounts for about 2 million visits in the ED per year, about 500,000 hospitalizations per year, and even greater than 4,000 deaths per year in the United States. And so when we think about factors that lead to severe acute asthma, we first have to consider that maybe even up to 50% of acute severe asthma cases are actually associated with a respiratory care tract infection. Beyond that, we have to think about allergen exposure, irritant inhalation, non-steroidal anti-inflammatory exposure in folks that have an aspirin allergy, exercise, and sometimes there's genetic issues that relates to asthma severity. And then a lot of our cases of severe asthma are in our folks that have very low adherence to their daily maintenance, whether they're not taking their inhaled corticosteroids or their oral corticosteroids as directed by their medical team. So, like I said, this is a medical emergency, and we mentioned a second ago that it's up to 4,000 or even more than 4,000 patients per year die because of severe asthma. So the question is, why do they die? What is actually getting them? So there's been some autopsy reports that show that there's anatomic changes in those folks, and they have mucus plugging, airway narrowing as you would expect, hyperinflation, and even regional collapse and atelectasis in those lungs. And so you can see, putting that together, again, with the mucus plugging, the collapse, which would cause hypoxemia, the airway hyperinflation maybe could lead to confounding factors like pneumothorax. You can see why this is a very severe condition for many people. When we think about general patient assessment, so a patient comes in your emergency department, what are we looking at? So one of the first things we have to think about is their history, which could very well be difficult to ascertain or get them to tell you because they may not be willing to be so conversational with you. But if you could find out if they've ever had any past hospitalizations or ED visits, have they been to the ED 3 or more times in the past year for asthma, have they been admitted to the ICU for asthma, have they ever been intubated for an asthma exacerbation, and if you find that information, this is very helpful because all of those things that I just mentioned are actually risk factors for a fatal asthma attack. So again, a patient comes into your ED with a history of being intubated for severe asthma, that should raise your concern. We can ask them about their frequency of albuterol use, whether it either associated with that asthma attack or how long it's been going. Maybe it's day 3, they've been using their inhaler for every 4 hours for the last 3 days. That's good information. We also like to know what current medications they're actually taking, such as their corticosteroids or oral steroids. And actually even want to know if they're having any illicit drug use. It's good to know if they've had any exposure to allergens or irritants, and if they have any other significant medical conditions that may complicate or be associated with, or at least complicate, their asthma attack. In terms of the physical exam, very common symptoms of somebody who presents in your emergency department with severe asthma, you would expect to see some coughing, some wheezing, chest tightness, obviously their subjective feeling of shortness of breath, or that's dyspnea. But we think about the main focus is what we're trying to understand as clinicians in the ED is we're trying to gauge the severity of their disease. So when we look at we're thinking about their severity, one of the very first things we could do is try to measure or think about or look at their degree of hypoxemia. And so when severe hypoxemia occurs in status asthmaticus or severe acute asthma, this is a sign perhaps of impending respiratory failure. And we want to look for complicating conditions that's associated with the asthma attack like a pneumothorax. So think about it for a moment. So a patient enters your emergency room complaining of shortness of breath, coughing, and has all those signs and symptoms, and then you put the pulse ox on their finger, and if it's quite low, this is a very, it's a pretty ominous sign. So again, and we'll talk about chest x-rays in a moment, but we have to be thinking, are their saturations low because of the mucus plugging, perhaps atelectasis, or is there a condition in addition to status asthmaticus like a pneumothorax that's actually causing the problems? It's important for us to know. We also look at accessory muscle use and pulsus paradoxus. This helps get some understanding of the severity of their condition. What might you see of a patient who is really struggling and is truly having an asthma flare? Well, first, they oftentimes will refuse to lay down below 30 degrees. Their heart rate, they're tachycardic, oftentimes with a heart rate greater than 120. Again, now let's go back to the chest x-ray for a second and how beneficial it may be. Really, there's a lot of debate of whether or not a chest x-ray is useful. But again, if you have a patient who is hypoxemic, it may be worth getting an x-ray to assure that no coexisting conditions are present. If you can get a patient to do a peak expiratory flow rate, generally a PEFR, peak expiratory flow rate of less than 40 is considered severe, or obviously that's 40% of predicted values. And again, the hard part with peak expiratory flow in severe asthma is actually getting the patient to make an attempt at getting the number. Arterial blood gas analysis, that's a clinical decision. It may or may not be helpful. It really depends on what you're looking for. It has kind of been reported in the literature about what we would expect to see. So we see here that like in the early stages of an asthma flare, you have a patient who's tachypnic. Perhaps you would expect to see a respiratory alkalosis as their PaCO2 drops. And in a lot of cases in early asthma, or perhaps if it's not so severe, their PaO2 will be normal even on room air. That would be a pretty average, I wouldn't say average asthma flare, but before it's severe, it's more of a mild to moderate asthma flare. Kind of a stage 2 blood gas, or in the second, as the asthma flare is perhaps worse, we also may have a respiratory alkalosis due to the hyperventilation, and the PaCO2 would be quite decreased. But in this case, you may actually see a decreased PaO2, again associated with perhaps mucus plugging or atelectasis or some of the other conditions that cause a patient to be hypoxemic. This is a very common finding in the ED setting, again, maybe some mild hypoxemia. As we move towards a more severe asthma situation, you actually may find a normal pH and a normal PaCO2. While the numbers are normal, you have to bring this one into context. A patient who is quite tachypnic with a normal PaCO2, that is actually an uncommon finding. Think about it for a moment. If somebody's breathing 30 times a minute, you would expect in a normal situation that their PaCO2 would be low. If it's not low, then we have to investigate that and be thinking that ventilation is actually not as good as it should be. This could be a sign of impending respiratory failure. Now, obviously, if I have a respiratory acidosis in the setting of asthma, then clearly that's an elevated PaCO2. This is also a sign of impending respiratory arrest. So what does respiratory arrest look like, or impending respiratory arrest look like beyond the blood gas? Again, the blood gas would show an elevated PaCO2, a decreased pH, and perhaps even a significantly decreased PaO2. So our oxygenation status will be poor, our ventilation status will be poor, and that information would perhaps lead us to escalation of therapy, including intubation and mechanical ventilation. What do these patients look like? Well, oftentimes they're confused, or perhaps they're severely agitated. They could be lethargic, even sleepy. It's described in the literature, and we describe it at the bedside as having silent chest or even absent breath sounds. Not only there's no wheezing, there's just no breath sounds, which implies there's no airflow. You could have paradoxical breathing or even bradycardia, which would be associated perhaps with being severely hypoxemic. So briefly what I want to do is I want to put you in the mindset of a case. Let's talk about, let's say, an average severe asthma case coming in your emergency department. And what I would like to ask you to do is follow me and think about what you would do and just kind of bring in a patient context to this so we can kind of draw a mental picture of what this may look like. So the case I have here is a 22-year-old male with a significant history of asthma that was intubated last year for asthma at an outside hospital per his report, and he was admitted in the ICU times 2 days. He is tachypnic at a respiratory rate of 32. He's tachycardic at a respiratory rate of 122. He has wheezing bilaterally, speaking in short, choppy sentences. His SpO2 is 89% on room air, and that's an important thing to remember, that we're on room air. And that's out in triage, and your patient is also diaphoretic. So again, 22-year-old guy, tachypnic, tachycardic, diaphoretic, short sentences. It looks like asthma. It is asthma. The first thing I want to talk about or think about is what do we do about those saturations? So the saturations are 89. So what should we do about O2 therapy? Oxygen therapy may or may not be needed in asthma, but in this case, perhaps it is. And generally, you would see oxygen therapy indicated in moderate to severe asthma. In reality, there's really no clear recommendations of how to titrate oxygen in an asthmatic patient, but it's generally reported to keep our saturations of greater than 92 or greater than 95 in our pregnant asthmatic patients. It is thought, though, that careful titration of oxygen is better rather than just giving somebody really high FiO2s. So it's probably better to titrate, for sats to 93 to 95%. Rather than just giving 100% oxygen at the time. And there's a little data to support this. So in thorax in 2011, there was a study here that was a randomized controlled trial of high oxygen concentration versus titrated oxygen therapy in severe exacerbations of asthma. And the authors of this paper concluded that high oxygen concentration increases the risk of hypercapnia during severe exacerbation. Oxygen titration is recommended during the treatment of severe asthma. And basically, in simplistic terms, they say only to give oxygen to patients that are hypoxemic, only give a dose or amount that's needed to relieve the hypoxemia, and do what you can to avoid hyperoxemia in those folks. So again, in a case of the respiratory therapist, it's probably better for us to give them the dose they need rather than just put them on a lot of oxygen and be a little more careful in titration. That seems to be what the literature tells us to do. And then, of course, you can't talk about asthma without talking about bronchodilator therapy. And so this is what RTs do, but really the question is how much do we give and what dose do we give and what med works best, right? So we know we have albuterol that is generally recommended in severe asthma at 2.5 to 5 milligrams every 20 minutes or so, generally for about 3 doses. You can actually treat using a meter dose inhaler if the patients are able. Obviously in a severe case, a patient may not be able to cooperate or be able to use inhalers correctly, so nebulizer may be better. But if you do have a patient who prefers to use an MDI or can use a meter dose inhaler, you may have to give 4 to 8 puffs about every 20 minutes up to 4 hours, and then every 1 to 4 hours afterwards. Continuous albuterol therapy is generally recommended at 10 to 15 milligrams per hour continuously, perhaps if that happens after you've given your intermittent aerosol therapy treatments. Levalbuterol dosage recommendation is generally 1.25 to 2.5 milligrams every 20 minutes is needed for 3 doses, and then perhaps 1.25 to up to 5 milligrams every 4 hours as needed afterwards. What about ipratropium bromide? It's actually recommended. Ipratropium bromide is recommended and should be given with albuterol in severe exacerbations in the emergency department. The next question is what about one versus the other, albuterol versus levalbuterol? What we know now is there's really no difference in side effects that are reported. Levalbuterol is not superior to albuterol actually in safety and efficacy. Both work, so I'm not here to recommend one versus the other. It's just not really thought that levoalbuterol offers really anything different than regular albuterol would clinically. And here is a chart here that gives us our dosing schedule that I just basically mentioned to you here, but this is actually published in a paper by Schauer in 2013 that leads us to the 2.5 to 5 milligrams for albuterol and the 1.25 to 2.5 milligrams for levoalbuterol and so on. Generally, in severe or even moderate to severe asthma flares, we have to consider systemic corticosteroids. And this is really, it's an essential part of acute severe asthma management. And persistent airflow obstruction that is unresponsive to bronchodilators alone, you certainly need to be considering giving systemic corticosteroids to offset or to mitigate or reduce the inflammatory effects or the inflammatory component of asthma. And it is thought that systemic corticosteroids are best when given earlier because of the onset time for them to work. Interestingly, the optimal dose of systemic corticosteroids is actually unknown. We have different ways of delivering corticosteroids, or oral steroids versus intravenous steroids if you have lines. But interestingly, when the doses are similar, oral and IV steroids are both effective, and they're identically effective, even in terms of onset. And if given intramuscularly, though, you have to think that onset of action is a little bit slower. Interestingly, when the doses are similar, the effects are pretty much identical, and the onset is even about the same. However, if you have to give a steroid intramuscularly, the onset of action will be somewhat delayed. And here you see in this graphic here that's been published also in 2013 by Schauer, just says that the prednisone dose may be things like 40 to 80 milligrams a day, and then you can see there the subsequent dosing schedule for the other meds. And so let's move back into our case. So before we kind of go back into our case formally, let's kind of recap. So we had a 22-year-old guy who enters our ED, tachypnic, tachycardic, diaphoretic, short sentences, and we'll say that what you've done now is we've given nebulizers times 3. You've given IV steroids. It's been about an hour since he entered your ED. He still seems extremely short of breath, despite the fact that he's had, let's say, 3 treatments of 5 milligrams of albuterol and ipratropium bromide and steroids. So the patient's not exactly worse. He's not exactly better. So the question I'm asking you is, what now? What do you do now? Continue therapy or add anything? Some of the things that we can add, perhaps, is magnesium sulfate. So magnesium sulfate is thought to cause relaxation of the bronchial smooth muscles as it inhibits calcium influx to the smooth muscle cells. It may have some anti-inflammatory effects, and benefits are shown in severe cases of asthma, severe exacerbations of asthma. The results, when studied, are a bit conflicting. This study here in Lancet is intravenous or nebulized mag sulfate versus standard therapy of severe acute asthma. This is a double-blind randomized control trial. You see here that our findings suggest nebulized mag sulfate has no role in the management of severe acute asthma in adults, and at best it's only really for, there's a limited role for IV mag. Another study here that's published in a Cochrane review, IV magnesium sulfate for treating adults with acute asthma in the emergency department, and this review is a bit more supportive, and it shows that IV mag reduces hospital admissions, improves lung function in adults with exacerbation of asthma, and so this gives us some thoughts that in severe asthma, mag sulfate may actually be useful. So how do you dose it? How do you give it? Dosage is generally 2 grams infused over about 20 minutes. Mag does have an excellent safety profile. It's contraindicated in patients with severe renal insufficiency, and actually may cause some muscle weakness. And so again, for a long time it was hard to understand how to dose magnesium, but it appears that 2 grams over 20 minutes is probably the best thing to do for those with a severe acute asthma. So let's continue on with our case. So now it's 2 hours after arrival. Continuous bronchodilators, let's say continuous albuterol is being given. You started at, let's say, 15 milligrams. We've already increased now to 20 milligrams an hour. Mag sulfate was given. The patient tolerated it well. The vital signs are slightly improved, and the patient continues to have increased work of breathing, and he states to you, I'm getting tired. It's getting really hard to breathe. I just feel really tired. And so Then what are my choices? Well, some logical choices that we have available to us in most of our emergency departments are Heliox, non-invasive ventilation, intubation and mechanical ventilation, and there's other therapies that are available as well. So let's talk about the first one here. Heliox is colorless, odorless, tasteless, inert gas. It has no direct pharmacologic or biologic effects in reality. It does not have any bronchodilatory effects. It does not have any anti-inflammatory properties. We may have different mixtures that are 70-30, so it's 70% helium, 30% oxygen, or 80-20 mixture that's kind of more closer to a 21% oxygen, 79% helium mix. So what it does is it decreases gas density and basically takes our turbulent flow and kind of creates a more laminar flow state. And the more laminar flow decreases airway resistance. So what's the data on Heliox? Well, in reality, like some other things, like our MAG, data on Heliox is actually a little bit conflicting. Generally, it is not recommended in the treatment of severe asthma due to insufficient evidence that it works. Data does support using Heliox in the care of patients with moderate to severe acute asthma as a nebulizer driving gas. And the use of Heliox is really based on sound principles and can be safely administered. It may provide benefits for patients with severe impairment and lung function. So if you're comfortable using it, it may work. Then again, in severe cases, it may not. The evidence is just simply not clear of whether or not it should be routinely used in severe acute asthma. What about non-invasive ventilation? So the role of non-invasive ventilation in acute asthma is still being investigated in reality, and it's not yet known. There has been an analysis of a national review, Nanchel and others. They noted that there was an increased use of non-invasive ventilation in severe acute asthma and a decrease in the use of invasive mechanical ventilation for, again, life-threatening asthma. And other studies have shown promise in lowering worker breathing and improving gas exchange. SCALA suggests that non-invasive ventilation might be applied in asthma for folks as an alternative to intubation in patients who have failed a trial of standard therapy, like our bronchodilator therapy, perhaps even our MAG or corticosteroids, to prevent intubation in patients with mild, moderate acute respiratory failure who do not need immediate ventilatory support. Clearly, if the patient needs immediate ventilatory support, intubation is the route to go. Prevent acute respiratory failure in patients who do not have substantial impairment of gas exchange. And finally, to accelerate bronchodilation in patients who do not need mechanical ventilation. So what literature support is there out there? Well, again, there's several studies. I wanted to show you a couple case studies here that were reported. Even one is reported in our own journal, Respiratory Care. This was non-invasive ventilation in severe acute asthma by Cappiello and Hawker. This was published in 2014. They have an interesting case that they describe. That is a 35-year-old male patient who came in responsive. And we've got to keep our mind here that this patient was responsive and the mental status appeared to be okay. The patient was diaphoretic. Respiratory rate was 35 on an FiO2 of 1.0, which is 100% oxygen. And saturations were only 88%. The patient was placed on 12/5 bi-level non-invasive ventilation, so 12 IPAP, 5 EPAP, and placed on an FiO2 of 0.4. Albuterol was started on the patient at 40 milligrams per hour, and the initial blood gas on the patient was actually 6.95 with a PaCO2 of 126 and a PaO2 of 316, which is a very severe acidosis, clearly. After 90 minutes of non-invasive ventilation, they report that the PaCO2 had dropped from over 100, again, down to 63 millimeters of mercury. Non-invasive ventilation in this case was stopped after 4 hours, and non-invasive ventilation tolerance was supported with low-dose lorazepam. The patient was transferred to the ICU and subsequently discharged home after 3 days. So the authors of this paper, in this case study, they attribute their success to close monitoring in the critical care setting and the titration of lorazepam. And so again, this patient was severely acidotic or acidemic, very hypercarbic, but the mental status was of such that they gave the patient a shot on non-invasive ventilation and they were quite successful. Here in 2017, there's another paper that's been published in the Canadian Journal of Respiratory Therapy by Miller et al. And this is non-invasive ventilation in life-threatening asthma. This was a case series where what they looked at, or what they did or performed, was a retrospective study that looked at 62 subjects that received non-invasive ventilation for asthma. 20 of the patients met study inclusion criteria, and that inclusion criteria was a pH of less than 7.25 and a PCO2 of greater than 60 millimeters of mercury. Intubation was actually avoided in all 20 of those subjects. And so, thinking about it, the authors conclude that non-invasive ventilation is safe and effective in the presence of severe respiratory acidosis or altered mental status. And again, this is based on retrospective data, and but it's interesting how this was a step towards understanding how well patients that are severely acidemic may respond to non-invasive ventilation. But let's look at our current evidence in terms of what we know and what are the general guidelines and recommendations. So we have a ERS-ATS clinical practice guideline on non-invasive ventilation for acute respiratory failure that was published in 2017 in the European Respiratory Journal. And what they did in this paper was they looked at acute respiratory failure for many reasons, and they tried to answer the question like this: should non-invasive ventilation be used in acute respiratory failure due to acute asthma? And the answer, the recommendation by that group was, given the uncertainty of evidence, we are unable to offer a recommendation on the use of non-invasive ventilation due to asthma. So they don't feel that, compared to the many reasons people may have acute respiratory failure, it's not clear whether we should or should not use non-invasive ventilation. So when compared to the others, for example, hypercapnia with COPD exacerbation, you can see that asthma has no recommendations made at this time. So is it clear or not whether or not we should be using non-invasive ventilation? Some case studies say it may work, some smaller studies say it may work, but in reality we need larger studies, we need to get more of a clear picture of what we should do. Now, so somebody fails non-invasive, they fail Heliox, they fail albuterol or bronchodilator therapy, they fail everything else. What we have to do at some point in time is we have to intubate and mechanically ventilate. Intubation and mechanical ventilation occurs in about 2 to 4% of patients with acute asthma exacerbations. And so the indications for mechanical ventilation and intubation and severe acute asthma are respiratory arrest, extreme exhaustion, and altered mental status. This is tricky. We have to be real careful here with these folks. Once they are heading towards needing intubation, there may be a lot of hyperinflation. They may be severely hypoxemic. And so this is a very risky procedure that needs to be done very, very carefully. So we have to approach this with caution. We need to ensure the patient has adequate vascular access if we need to try to augment blood pressure for either from the medications or because of the hyperinflation causing a decrease in cardiac output. It is recommended that the most experienced person intubates this somebody who's in a severe acute asthma flare that needs intubation, and nasal intubation is generally not recommended. In terms of how to get a patient intubated, rapid sequence intubation is generally recommended as it is quick and it has a high success rate. And remember that these patients are really at risk for a rapid decline in their status, especially when sedated. Intubation medications, again, that's going to be the individual decision of the team based on the scenario that you're in, but medications are things like etomidate, which is less likely to cause hypotension when compared to drugs like propofol. Ketamine has actually been described in the literature to be used in intubation of somebody in severe acute asthma. Ketamine, interestingly, actually has some bronchodilatory properties, but it's thought that more studies are needed to know whether or not it plays a role in intubation during an asthma flare. Propofol is a very quick-acting drug similar to etomidate, and it may also have some bronchodilatory properties, which obviously would be beneficial in a patient with severe acute asthma. You just have to be careful, as this may cause hypotension. Avoid drugs that cause histamine release. They're already having enough problems, so we don't need to cause histamine release from drugs like barbiturates. The major goals of mechanical ventilation, so what are we trying to do, is we're just going for adequate oxygenation. We're just oxygenate enough to be safe, to decrease or lower the work of breathing for the patient, and to prevent lung injury due to air trapping. So the settings in mechanical ventilation for our asthmatics are, we have to think about our tidal volume and our respiratory rate. So general recommendation for tidal volume is generally 6 to 8 mLs per kilogram, and our respiratory rate maybe 10 to 12 breaths a minute. Now this is perhaps a bit slower than you would set for another patient without asthma. Again, you're trying to allow more time for the patient to exhale, so the total cycle time would be a bit longer here if your rate is a little bit less. Really the goal here is prevent air trapping. So we can do this again by keeping our rate low, or perhaps lowering our I time or inspiratory time by increasing our inspiratory flow rate if I'm on a volume control or volume targeted mode, or decreasing my inspiratory time if I'm on a pressure mode. So a normal inspiratory time is generally accepted as 0.8 to 1.2. So perhaps if you have a patient who has a prolonged expiratory phase, you may have to turn your I time down more close to 0.8. In terms of PEEP, it's generally recommended that PEEP on a severe acute asthma patient be set at 5 or less. You may have to increase your PEEP actually to offset trigger asynchrony. And in terms of your FiO2, simply set your FiO2 to keep your saturations greater than 90%. Again, we're trying to avoid hyperoxia, so just keeping normal saturations is really your target. So again, we have to think about the complications associated with mechanical ventilation. So if we have to intubate a severe acute asthma patient, we have to immediately be concerned or be thinking about the complications that comes from intubating this population. And so right off the top, we have to think about barotraumas. It's been reported that about 3 to 6% of patients that are intubated for severe acute asthma actually experience or have pneumothorax or pneumothoraces. So that's actually quite a bit. And as you know, a pneumothorax can be quite dangerous and even life-threatening. And so this must be recognized and treated quickly. Hypotension has also been reported as a complication or as a known complication of intubation and mechanical ventilation of these folks. This is generally related to hyperinflation and the decrease in venous return due to the high intrathoracic pressures. An unfortunate complication of intubation and mechanical ventilation of severe acute asthma patient is cerebral anoxia, and this is either from a prolonged intubation or complicated intubation, or perhaps if they have cardiac arrested prior to intubation. So clearly, the prolonged intubation, the saturations falling, or the cardiac arrest could lead to cerebral anoxia or even ultimately brain death. And myopathies are also known complications of intubation and prolonged mechanical ventilation of asthmatics. It's sometimes due to sedation and paralysis, which is not uncommon in the setting of severe acute asthma. So let's take a second to talk about other therapies. So we've kind of covered bronchodilators, we've talked about corticosteroids, we've talked about magnesium sulfate, we've talked about Heliox, non-invasive ventilation, and even up to mechanical ventilation and intubation. Something else that's reported in the literature somewhat is anesthetic gases, actually, and because anesthetic gases have some bronchodilatory effects. Halothane, isoflurane, sevoflurane, all of these have some kind of bronchodilatory effects. But in reality, it's probably not feasible, at least in the ED environment, as these anesthetic gases are first, they're expensive, they require anesthesia personnel and specialized equipment to use. Some of the other bronchodilators that we have available to us are actually intravenous or intramuscular beta agonists like terbutaline. These are generally avoided because of the tachycardia and the arrhythmias that are associated with them. Some inhaled beta agonists, it's thought that inhaled beta agonists are more efficient, they have less side effects, and they're probably as good or better than these IV bronchodilators, especially because of the risk of side effects. So let's take a look at some therapies that are not generally recommended for acute asthma. Intravenous methylxanthines are generally not recommended. Empiric antibiotics are generally not recommended. Nebulized furosemide, expectorants like guaifenesin are not recommended. And antihistamine therapy is not recommended. And chest physiotherapy, while being reported in the literature, is not generally recommended during an acute asthma flare. So let's take a step back just for a moment and let's look at a case and kind of wrap everything up that we've talked about today and try to create kind of a logical thought of how we would work ourselves through a case of severe acute asthma. So let's Let's use the case of like maybe a 35-year-old female presents to your emergency department by way of EMS. And let's say en route she received 2 treatments, 2 bronchodilator treatments of albuterol, 2.5 milligrams each. And so as she enters your emergency department, she continues to be tachypnic and tachycardic, diaphoretic, speaking in very short sentences. What she does say is she's very short of breath, and this seems very typical for her severe acute asthma. And so you being a respiratory therapist, understanding the importance of her history, you start to investigate how severe her asthma is in terms of what's been going on maybe for the last year. Let's say that she's been intubated actually within the last year at least one time, or she's been to your ER 4 other times, and 1 time or 2 times she was admitted to the ICU. And so if you think about that in itself, that would give some idea of how severe her asthma can be, and it gives us an idea of how well she responds to conventional therapy. So now we realize because she's been intubated, because she's been in your ICU, because she's been to the ED so many times, she's got pretty severe asthma. So what are you going to do now? So a recommendation could be to go ahead and continue bronchodilator therapy. Perhaps we'll increase our dose of albuterol maybe to 5 milligrams and also give ipratropium bromide. This may be a case where the nurse or the doc or whoever starts an IV and we go ahead and get those corticosteroids on board. So we have bronchodilator therapy being given and we have corticosteroids on board. So what's next? Well, if this is severe, if you deem this to be a severe case of asthma, then perhaps it is time now for the 2 grams of MAG via IV. And then so now we would have, again, the bronchodilators, the steroids, the MAG therapy on board. If she continued to be short of breath and even not very responsive to the therapy at this point, then perhaps a move would be to Heliox, or the move would be to non-invasive ventilation. For the sake of discussion, let's say that you choose to use non-invasive ventilation. And if you do so, what settings might you use? And there's really no recommendations to what settings one would use in the setting of status asthmaticus or severe acute asthma. We've already talked about this, it's not even recommended or not recommended at all because the data is just not clear. But for the sake of discussion, let's say that you start at 12/5. And you start her at 12/5 and she seems to tolerate the mask fine, but her tidal volumes are quite small and her respiratory rate is still very high and she appears to be working, her work of breathing is still quite high. What would you do? Perhaps the right move might be to increase her IPAP level, let's say from 12 to 14. Perhaps that's enough to offload some of her work. And so now you have bronchodilators being given, those can be given through a non-invasive circuit. You give corticosteroids, IV MAG, and now non-invasive therapy. And then really our role is for continuous evaluation of whether or not the non-invasive ventilation is working or it's not working, if her mental status is changing. And so hopefully what we can do is we can use things like Heliox, or in our case, non-invasive ventilation, to hold her over just long enough for the bronchodilators to do their job and for the corticosteroids to reduce inflammation. And if that's done, perhaps we can avoid endotracheal intubation and mechanical ventilation and the numerous complications associated with intubating and providing mechanical ventilation for somebody in severe acute asthma. To conclude, we know that severe asthma can be life-threatening. It's been reported that this causes greater than 4,000 deaths per year in the United States. The goal of therapy is the prevention of morbidity and mortality. Rapid assessment is key, and initiation of therapy quickly is key. We know that quick bronchodilators is the right thing to do, and quick corticosteroids is the right thing to do. Ongoing assessment is key for us. Teamwork and communication is vital between all team members, so we know the patient's getting better or getting worse, and we communicate and we come up with a plan that's safe and feasible and it provides the best patient care possible. And finally, with everything that we do, the evidence-based approach to treating severe acute asthma is always best. And with that, I'll leave you with some references for future reading, and I do appreciate your time and attention. Thank you.